All right, so this is going to be from chapter 26, which is soft tissue injuries. A lot of what we have already discussed is going to be covered in there as far as managing bleeding and identifying different types of injuries, which we learned in the secondary assessment of DCAT BTLS. So I wanted to spend the majority of our time in this chapter looking at burns because I think that's something that is very unique. And the treatment is quite different than that of hemorrhage control. So that's where we're going to pick up with this. So burns account for approximately 3,400 deaths per year, and these are among the most serious and painful of all injuries. A burn occurs when the body receives more radiant energy than it can absorb. So as opposed to our kinetic energy or potential for energy, like we discussed previously, this is coming from radiant energy. So we want to always perform a complete assessment to determine whether the patient has other serious injuries. Children, older patients, and patients with chronic illnesses are more likely to experience shock from burn injuries, and there's a lot of reasons for that. Generally, they have thinner skin, they have less subcutaneous tissues, and they're less responsive to temperature changes. So rather, they have less ability to maintain their temperature if something has disturbed it. So looking at the pathophysiology of burns, these are soft tissue injuries that are created by the transfer of radiation, thermal, or electrical energy. Thermal burns occur when the skin is exposed to temperatures higher than 111 degrees, and the severity of the thermal injury correlates directly with the temperature, the concentration, the amount of heat energy possessed by the object or substance, and the duration of exposure. So we're going to talk about some things that we can ask about. The greater the heat energy, then the deeper the wound. The exposure time is a huge factor. People reflexively limit their heat energy and exposure time. They might realize that it's hot, so thinking about reaching out and touching the stove, but also thinking about our children and our elderly population, how they might have diminished ability between those sensory nerves to recognize that they are in pain or that something is hurting them before they pull away. So some complications of burns. When a person is burned, the skin that acts as a barrier is destroyed. So burn victims are at a really high risk for infection, hypothermia, hypovolemia, and shock. Burns to the airway are of significant importance as well. So thinking about whether this is inhalation of overheated or superheated gases that could have gone all the way down, or whether this is like soot, looking for those types of potential things around the mouth and the nose to let us know that the patient has been exposed to this. We want to be really aware how quickly that upper airway can swell. Also circumferential burns, and this is talking about circumferential burns to the chest, but really circumferential burns anywhere are significant. So circumferential meaning it's all the way around. So whether that's completely 360 around an arm, a leg, or the chest and abdomen, it is very significant because the body doesn't have room to allow it to swell, and so you start to have neurovascular compromise and eventually irreversible damage from that. So we're looking at the severity of burns. Again, it's going to depend on the depth, the extent of the burn, the critical areas involved, any pre-existing medical conditions, and then our very young and very old. So the depth of burns are classified as 3. So that is first degree or superficial burn, second degree or partial thickness burn, third degree or full thickness burn. And so these are a few examples of that, and you can see it both in the graph up top and then also the pictures down at the bottom. Our superficial burn being more like a sunburn. Then kind of in the middle, you see this is very painful, and the blisters are really what's key here to make this a second degree. And then in the third degree, this is all the way involved down to the muscle. It's fully involved. The hair follicle is burned off. There are no blisters. The skin is charred. This is not painful, but because it has burned through the nerves. So if you have a patient that looks like what you see there in that last picture on the bottom right and is not having any pain, that's very significant. As you can see, he's already having his airway managed, but that would be definitely of utmost importance here. So how we can estimate the extent of the burns is a couple of different ways. So we can estimate this being the rule of palm or the rule of the nines. The proportions are going to differ for infants, children, and adults. and we only want to include partial thickness and full thickness burns in the extent of the injury. So that means if they do have any first degree, then that would not count towards the extent. We're looking at second and third degree or partial and full thickness burns to determine the extent burned. And so the rule of palm is really the simplest, and that is your palm. Okay, so the size of your palm is 1% of your body surface area. If it's a small child, if it's an adult, whatever it is, it's their palm. So the size of their palm is approximately 1% of their total body surface area. So if that's 5%, 20%, however much based off of their palm. Now you do need to know this rule of nines, and this you will see on test questions, and you're also going to see this on your state exam, national registry exam. It is something that is talked about over and over, so make sure that you are familiar. Like we said, the reason it's called rule of nines is because usually it is 9 for each area of an adult's body. So that is 9 for each arm, that is 9 for the head, it would be 9 for the chest, 9 for the abdomen, they've put those together to make 18, 9 for the front of the leg, 9 for the back of the leg, for a total of 18. So you can kind of see how that's broken down. It is a little bit different for children and for infants, as you can see, just because their bodies are proportionally larger. So it really depends on, are you using the scale of rule of nines or the rule of palm to determine the body surface area that is involved, and that's how much you would make the determination from your call in. Now, again, it's where you transport to is going to depend on your area. If you're working in an area that has close access to the burn center, like here at UNC, Chapel Hill, they have criteria of what needs to be transported to a burn center. So if it involves a 1% critical area, which as you can see is your genitalia, or if it is your hands or feet, those need to go there. If it's second or third degree burns to the genitalia, the hands or the feet, those are considered very critical areas and need to go to the burn center for specialized treatment. Or then again, looking at your individual county's protocol, if it's 8% or 9% of a second degree or third degree burn, or any of those critical areas. So just take those things into consideration when you're making those judgment calls of where the patient needs to go. If it's less than that and it's still a burn but doesn't need to go to a burn center, then try to take them to a trauma center so that they can still manage that. So some things to consider when you're assessing the burns. We want to classify them. So again, we're determining what caused them, what is the source of the burn, what is the depth of the burn, and what is the severity of the burn. Okay, so how much is burned, how deep is it, that type of thing. And then they kind of cut off here in the PowerPoint and address the treatment later on, but I just want to talk really briefly about that and say the first step in treatment of the burn is going to be to stop the burning process. Okay, so if there's any fire, if it came from something they pulled down off a stove, like an oatmeal, things like that I have seen previously, you want to make sure that you stop that burning process first and foremost. Okay, and then we'll start talking about some treatments here. So picking up right here, looking at thermal burns, these are caused by heat, and they are most commonly caused by scalds or open flames. So coming into contact with hot objects can produce a contact burn. A steam burn can produce a topical scald, and then a flash burn produced by an explosion. Looking at management of thermal burns, like I said, is to stop the burning source first and then cool that area. But you don't want to put a whole lot of cold water there and leave it submerged, because you don't want blisters to begin to form if they haven't already. So you would want to stop that burning process, and you can cool it off with water, but then you're going to want to dry it and apply a dry dressing. Now, the biggest reason for the dry dressing instead of wet to these burned areas is because of temperature management. So if we have a patient that, it's just a small burn on their hand, then a little bit of a moist dressing, if it's more comfortable for them, might be okay. But especially if this is large surface area, then you're thinking about dry dressings to help maintain that body heat. We also are going to need our ALS personnel for pain management. That's a huge thing with burns. It is very, very important that we try to keep them calm and that we manage their pain. So calling for ALS for that is very important. Looking at inhalation burns, so we mentioned like superheated gases. These can occur when burning is taking place in an enclosed space without ventilation. So upper airway damage often associated with those superheated gases, and then lower airway damage down moving into the actual alveoli. That can happen with chemicals or particulate matter. So it can cause severe upper airway swelling, or it could be a combustion that's happening there with toxic gases. So things we're looking for: stridor, if the patient has a very hoarse voice, singed nasal hairs, burns on the face, any type of soot that's there around the mouth or nose. Those should be real red flags to us that this patient likely has an inhalation burn, and we need to get ALS there to help us manage that as quickly as possible, because they might need to be intubated. Other things to consider: carbon monoxide poisoning, considered if they've been in an area where they all have the same symptoms, and we've kind of talked about this before, but that could be coming from burning or something like that. So even if they weren't exposed to the actual fire or temperature burns or thermal burns on themselves, it could be coming in the form of airway. So chemical burns we've talked about before, as far as making sure that we brush off any dry chemicals before applying water, that we have the appropriate PPE for ourselves, that they are being properly decontaminated, so on and so forth, as far as management of the chemical burns. Electrical burns, these can occur from contact with high or low voltage electricity. So there's got to be some kind of conductor for this electricity to flow, and that conductor, a human being, is a great conductor, all right? So energy can flow really quickly through that, and so we want to make sure that we are looking at several things here. Your safety, of course, is very important. Has it stopped? Is there still electricity that's flowing through them? If you don't see any obvious exit wounds related to the electricity, then likely it's still coursing through their body. Generally, electricity can cause blowout injuries, which can cause fractures anywhere on the body, wherever it's happening at. So very important that we're recognizing the things that are going to be a threat to us first and foremost, that the patient is not lying in water that could transfer that to us. That's also a really good conductor, that type of thing. So just looking at the types of injuries we could see here, two dangers could be a large amount of deep tissue injury and also cardiac and respiratory arrest. As we'll talk about in our talking about environmental, we'll talk about more lightning strikes and things like that. But anytime that we have an electrical incident, we need to be prepared to manage a cardiac arrest, because that electricity could have potentially caused a disruption in the heart. So staying aware. This is what one of those blowout injuries that I mentioned could potentially look at. So looking for treatment of this as well. And then if indicated, again, as we said, start CPR, so supplemental oxygen, go through your normal cardiac arrest management treatment, and then looking at the injury treatment secondary. All right, so that's going to be it for burns. I'm going to stop this portion of the video here. If you have any other questions about the remainder of this chapter, please let me know.